Efficiency Unlocked is hosted by two tech-savvy physicians and dear friends of mine, Drs. Adam Carew and Dale Gold, who are experts in using technology to automate routine tasks and increase efficiency in everyday and business life. Let's see what they have for us today.
That's one of the joys of medicine, is to try to really get to the right answer. And the right answer is so unique to each individual. So I see a future where all of those things come together, and it's not just what have we done 5 or 10 years ago, or even in medical education, it's not just what did your mentor tell you in medical school that maybe they did 10 to 15 years ago, but what actually should we be teaching people, and how up to date should that information be so that they can take the best care of the patient.
You just heard Dr. Jackie Gerhart, Epic's Chief Medical Officer and VP of Clinical Informatics. Now, get a sneak peek behind the scenes at Epic's strategy to revolutionize healthcare. From harnessing AI to reduce clinician burden to leveraging big data for personalized care with their new tool, Cosmos, Dr. Gerhart shares how Epic is transforming the care experience. Stay tuned for an insider's look at the future of healthcare technology.
All right, welcome to this week's episode of NerdMD's Efficiency Unlocked. I'm here with my co-host, Dale Gold. He's on most of the shows, for those of you that listen to all of them. How's it going, Dale?
Hey, Adam. Yeah, it's going great. I'm excited for our guest today.
Yeah, me too. I think we cold emailed this company a while ago trying to get someone, and we're really excited. We have Jackie Gerhart here. She's the Vice President of Informatics at Epic. Not Epic, the gaming company, but Epic, the EHR company, based out of Wisconsin. And Jackie is a physician as well, so she fits well into this NerdMD's mantra. So Jackie, welcome to the show.
Thank you so much. Great to be here with two family docs as well.
We're really excited to dive into your history and learn a little bit more about you. Before we go too much into the Epic space, can you tell our listeners a little bit more about what brought you into healthcare and the clinical side?
Yeah, so I, by background, am a techie. I did biomedical engineering. And actually during college, I was doing an internship on medical devices and realized that I preferred doing medicine with people and speaking to people and solving problems than sitting behind a desk and running experiments over and over again. And so I kept with me some of that experimentation and still do some research, but I really found my way into medicine overall. I ended up going to Mayo Clinic in Rochester, Minnesota, and they're known for specialties. And so I was guided to multiple different specialties, but actually loved everything. And so I kept coming back to what's a specialty that I can do everything, serve everyone, really think about being a quarterback of care. And that brought me back into family medicine. So I practiced family medicine at the University of Wisconsin for about 7-8 years as a full-time family doc. So inpatient, full scope, inpatient, outpatient, OB, nursing home, you name it, residency teaching, med student teaching, loved it. And was not at all burnt out, but got to the point where I really wanted to paint on a broader canvas and have the ability to impact a lot of other arenas in addition to my direct patient care. And so I kept practicing, but switched instead of from full family practice to urgent care. And so I still do that on evenings and weekends in my free time. But then I work full time now at Epic. And really my informatics background had been doing some informatics at UW Health, but really diving much more deeply into it when I got here to Epic. And since then, I really focus on two main things. I'd say a lot on generative AI and a lot on Cosmos, which we can get into. But we have 14 physicians here at Epic out of 14,000 employees. And so we're a small but mighty group. And really our goal is to try to make sure the software is a joy to use, and also that we're really helping clinicians take the best care of their patients.
Yeah, love that, Jackie. Yeah, and I think you mentioned some of these clinical roles that you have and that you still dabble, right, in some urgent care. I think you posted a photo over one of the recent holidays. I don't know if it was New Year's or whatnot, but it looked like you were doing an urgent care shift, right?
I did. Christmas. Yeah. I love Christmas for urgent care shifts because people are so grateful to see you, and oftentimes they have really significant problems because they would want to stay at home with their family if they didn't. So it has some both good mental exercise from an intellectual standpoint, and also it feels very caring.
Yeah. And I guess the follow up to that too is do a lot of the physicians that work on the Epic team with you, do they still do some clinical, or have some given up kind of all that clinical work?
We have a team that ranges from anywhere between a couple of years that have worked here all the way to over 25 years that have worked here. And so there are some that have let their practice go, and there's others that, came right into it. So there are informaticists on the team that after residency decided to go right in without practicing. And so we have a variety of different specialties that are here. And I think it depends just a little bit on if you're able to carve out times on evenings and weekends. Not every specialty is put out to that.
Great.
And I think you alluded to sort of having, more of a tech background, at least early on before you found the clinical piece. What actually helped you find sort of the informatics opportunity, or was it the opportunity to Epic that turned into informatics for you?
Yeah, a little bit of both. So I got to the point about 7 years in where I wanted to be more innovative, and being at a academic institution, as innovative as they can sometimes be, they also often have a lot of committees that meet with committees, and then there's different red tape and so forth. And I felt myself eager to take on new technology, even to the point where I was doing OB at the time. And I remember this sort of industrial engineering problem where there was one ultrasound machine, it was in one closet, and the checkout process was horrendous. And the idea, I actually ended up having a patient, it was her third pregnancy. She had had 2 vaginal deliveries, and her third one was, and by all accounts, going to be vaginal as well. And I could feel that she actually, on Leopold's exams, that actually she had a breech pregnancy, but I couldn't schedule her to get a version unless I got an ultrasound. And I struggled to just get this person in for an ultrasound. And it was that moment where I was like, but if I learned ultrasound and I just had my own ultrasound, I could just plop it on and be like, skull, got it. Like this, I know what's going on. I can solve this problem. And that's a silly example of something that, could probably be fixed from an operations perspective. But it made me realize that if I really want to practice the best medicine, I want to have the best knowledge, the best tools, and be able to have that spread throughout really everyone that practices. I don't want to send a patient to a specialist and have them not sure if they can use certain resources or not have the best resources available. And so as I was thinking about the health system as a whole, I really was wanting to go to something where I could really have more autonomy. And I looked at informatics and Epic, but I also looked at starting my own practice. And I also looked at thinking about being in tech, in biotech again. And really, it was an interview, my day here on Epic's campus, when I interviewed with Judy, that really blew me away and made me want to come to Epic.
Yeah. How many years now have you been at Epic?
About 7.
7. Okay. Can you kind of, can we so Dale and I, obviously we've both been practicing about kind of 12, 13 years, and we're always a part of an Epic organization. And, going back to Epic, I remember physicians were always a part of Epic, because I remember when we go back, there was always the physician academy or whatever it may have been called initially. And then the physicians always participated in some of the presentation from Epic as well. But how has the role in Epic kind of evolved, since you started to where it is now? Because I remember distinctly all of a sudden it seemed like it was officially called informatics, probably in the same way that Dale and I started, where we weren't informatics. We were just kind of the Epic physicians of Kaiser Permanente, and that slowly evolved as the specialty kind of evolved. But can you share a little bit about that too?
Yes. So early on, one of our earliest physicians, Chris Albin, is an emergency medicine doctor. And one of the main roles, early on and for the physicians, was simply to just demonstrate the software. So it was, hey, we're a new upstart company here at Epic, and we need to show clinicians how they can use it in their workflow and have it make sense and be efficient. So it kind of started almost as a sales demo role, but it's really grown from there. So over time, we each have conversations with our customers. So We each have around 30 healthcare organizations we work with, and we talk directly doctor to doctor, so often CMO, or both. And we will solve problems on those calls. And between the different physicians here, we talk about different things. Sometimes it can be informatics nitty gritty, like how are you designing that screen? What is the governance behind that workflow? Who do you have do you have the right people in the right seats at your organization to make this strategic change? But it also can be something like, these are the ways in which other organizations are using AI. What is your strategy? How does it compare to their strategy? And thinking beyond the technical and sort of tactical, and thinking more to what situations can we create in our informatics environment that are going to make most sense for our providers and our patients. So I think of it as 3 buckets. We demonstrate software, often now to international companies, sometimes who maybe even are still on paper, which is a wild thing to still see. And then thinking about customer service and strategy. And then the third part is really deep interaction with R&D. So not a day goes by when I'm not on the phone with a software developer, or literally in a room with a software developer trying to go through what is going to be the next thing that we can put out, and being sure that the next thing that we put out doesn't necessarily just move the cheese, but actually does something meaningful and helpful. And the panacea is to have it be easy and meaningful and also help with patient outcomes. And so that's how it started. And then I'd say for me, I have 3 more buckets, or 3 pillars that kind of have come on in the time that I've been at Epic. And the first one is generative AI. So definitely worked with AI early on in sort of the predictive models, but generative AI obviously has taken off much in the 2020s. And I do a lot of thinking on what tools should we put out and when, and how should they be experienced by the care team. And then the second bucket is Cosmos. So I mentioned that I like research. And so I'm part of Epic Research, which is at epicresearch.org, which is where we study the vast amount of data from the customer collaboration throughout our entire Epic community, and look to try to solve real problems, public health problems, individual problems, and then also see how that can be put into a workflow to help a clinician make shared decision-making with their patient at the point of care. So that's the second one. And then the third one, which I never thought I would do, is doing some stuff with government. I have been talking in DC a little bit with some of our customers around areas like AI regulation and AI policy and interoperability, and how is it that we make information flow in a way that allows for privacy but also allows for robust information exchange. So that's how it's evolved over time, and I'm pretty lucky to be part of some of those new efforts.
Yeah, I think that anyone listening probably would appreciate the value of not only having a problem solver, but an active family medicine physician who understands the work actually involved in, as you described, much more than demoing, but actually making sure that software that really impacts, so many people at different organizations and the patients that it can touch, the scale of impact that you describe, can be so huge. In terms of Epic history, how has it really progressed in your time in those 7-8 years from, really just what we originally thought EHRs would be to where we are today, and how is your new role involved in that?
We initially used EHRs as a way to keep track of information and a record of information. And Judy, back in 1979, put the patient at the center and built all of the different applications around the patient with the idea that it would all be integrated so that any clinician, any caregiver, any patient care team member was able to get the same information at the same time. So that really was the core basis of it. But then how it's evolved over time is there's so much more other than keeping track of what happened. At the time, she thought about it as there's things that don't often change, like your birthday. There's things that sometimes change, like maybe your weight. And then there's things that are always changing, like perhaps what you had to eat that day. And thinking about that kind of different information and getting it over time was a really complex math problem. But beyond that, what I think is even more complex is, all right, you've got some information now. What are you doing with it? And really the promise of the EHR is now that we have at our fingertips, at clinicians' fingertips, the ability to think more critically about personalized and precise care, how can we use that data that's there to help with quality, help with safety, help with outcomes, and really change the face of medicine? So I think it's really gone from this, it's something that I need to do so that my colleagues and I remember, to being something that really is empowering and engaging clinicians and their patients in the entire care journey.
Yeah, it's a great explanation succinctly of I think how EHRs have evolved, especially, specifically Epic. And, I think it's interesting because I think there's this misconception kind of maybe out in the public, around a lot of this stuff, like how much just the landscape of EHRs have changed, and honestly, even how much Epic has changed. I remember, I think when I first, my first, start with Epic was, it was very much just like it was software that the healthcare organization could configure however they wanted, right? And, I was working for Kaiser, which I no longer work for, but, Kaiser was one of the very early customers. And so they kind of personalized it in a lot of ways that, and I think some of the early customers of Epic, it got them, I don't want to say got them into trouble, but just like got them into a place where they weren't able to leverage the newest things that were coming because you were kind of down a path of development. And so I think, this is more just me anecdotally, like kind of thinking about how it's changed. And I remember when I was in the CMO role, I used to be kind of jealous of new organizations that came onto Epic, because I was like, oh man, they're getting like this fresh start where they're getting to start with this amazing base. Yeah,
you're absolutely right. That I was going to say, when you say early on configurability, one of the things that we've noticed the most difficulty with is helping customers that are so overly configured be able to take the latest and greatest stuff. And to your point, we have something called Foundation System now, which is the best and greatest of all the different smart sets and everything that an organization might need to do, rather than having to go in and recreate the wheel every time. Another thing you made me think of is a principle we have here called imitate to innovate, which means you don't need to recreate the wheel and specialize your system down to the super, super special snowflake level of whatever, your every specific clinician thinks they need. It's literally not taking what was on a piece of paper that an orthopedist used before and putting it in that piece of paper into an electronic form. Like that's not the point. The point is to try to make the process better. So how can we make care in general more efficient, not just recreate what we were doing previously on paper? And some of the coolest things that we're putting out right now, if you aren't able to have the change management to take them, it's one thing to put the technology in, but it's another thing to be able to say, all right, we're going to reframe the thinking of the clinicians that you're not going to practice the same way. You're going to practice in a better way, in an elevated way that's going to give your patients more quality, more safety, and really help your care be different than it was before. And that's really been helpful for a lot of our customers.
Yeah, that's the exciting stuff that, I think a lot of the, I don't know, I'll call it like the lay public or the folks that are getting care, at organizations, that are using Epic, don't actually know, right? Epic doesn't put out a lot of public things for the general public, to know. I think recently there's been a little bit more, more public facing kind of YouTube videos and those types of things, sharing some of the stuff. But I think let's like drill down into some of those new things next. And, I think specifically around like what you've alluded to and what Dale asked earlier about, Epic jumped in full force into the generative AI boom, that hit us all during really the midst of kind of the COVID pandemic, right? Or at least in the midst of the latter portion of it. Obviously AI right now, it's looking to decrease some of that administrative burden that so many clinicians are facing, and then you mentioned too, enhancing that clinical decision support by, having really good knowledge at the point of care, so clinicians can make the most informed decision, right when that patient is right in front of them or on the phone or on a video. Could you share kind of some of those examples, like around that, are live now or imminently live in that space?
So AI has been around in EHRs for a long time. I mean, we were talking about AI decades ago, and oftentimes that was simple rules-based logic or predictive algorithms. And so I think for listeners to appreciate the fact that there already are things that are in your system that are using AI, even if you haven't necessarily taken the GenAI leap. Remember that those sometimes are, if you don't have them turned on, turn them on, and sometimes those are still the best answer. So for example, on the rules-based logic, which we kind of consider on a spectrum of rules-based being on one end with like deterministic and targeted, whereas on the other end would be GenAI with almost more of a probabilistic characteristic to it. And so we think of rules-based logic as like drug-drug interaction. So that's an example that you've had forever, where you can get a notification saying you shouldn't prescribe this drug or a drug allergy interaction. That is just straight up rules-based logic and is used for safety every day. Whereas like a predictive algorithm, which we've again had for years, would be a sepsis warning score or a admission or likelihood to escalate care kind of score. And I think that has been used somewhat. And I think much of the discussions around AI and AI algorithms and their correctness and their drift and the more technical versions often talk about that type of AI, that how well does the algorithm fit the population and predict what it's supposed to. And then there's the generative AI, which is these new use cases you ask about, which is anything from thinking how to help a clinician to trying to empower patients. And so we at Epic, as I said before, we put the patient at the center and everything around them. When we think about GenAI, we're actually hearing from healthcare organizations that they just want us to get rid of the administrative burden and the stupid stuff. So it's not the way we went about this is starting by, okay, let's work with the doctor. What can we take away from the doctor that they don't need to do, that they don't need to be a clinician reviewing and solve that? And then what about the nurse? Okay, well, how can we, during staffing shortages and people that feel like they went into medicine but maybe aren't practicing medicine, how can we take that administrative burden away from them so they really feel like they're doing what they kind of meant to do? And then think about patients. So what AI can patients use? And I think we would all be naive if we don't think that our patients are already using AI to ask medical questions, much like they did, when Google first came out. And so how can we, as physicians who want to give the best information to our patients, help bring that into their experience? In Epic, it's MyChart. How do we bring that into their MyChart experience so that we can give helpful information from a clinical perspective and also help tailor the advice to be more personalized? So for examples that you asked for physicians, the one that is most widely used is AI charting using Ambient technology. So I'll put the phone between my patient and I, and we'll just have a normal conversation. And I've noticed that not only does that improve efficiency, you've probably seen all the studies that show time savings, but there's other improvements too. I feel like looking at the patient in their eyes, understanding and really hearing them, actually the efficiency also helps me sometimes get to other information in their chart. So closing care gaps, maybe addressing something I wouldn't have otherwise had time to do. So there's a lot of wins on that front. And really the qualitative ones are the ones I like the most. The I got home for dinner, or the I feel like my marriage is saved because I actually have time with my spouse. Those are the ones that I think when I think about why I got into informatics really make it worthwhile. So those are some physician examples. There's also in-basket art, which is where the AI puts together a drafted response for a patient message. And then we have summarization, so inpatient and outpatient, so trying to get you up to speed on what happened either over the past few days for your patient in the hospital or over a certain amount of time in their history, depending on if they're a new patient or not. So those are some physician examples. And I'll pause there. I could go on and on. There's patient examples, but I really think it's something that is absolutely going to change medicine, already has. And we are so fortunate to be in this time and age now to be able to have that and see how that's going to impact patient care.
Yeah, absolutely. I think that, we've all been doing this work for a long time, but the inertia and energy to actually focus on this admin burden and the clinician well-being, has, come to a peak where, everyone agrees that it's time to do something about that. We can't keep running out of doctors, and we can't keep burning them out. We need to find a way to bring back that joy in medicine. And I think a lot of these do that. In my organization, in my region specifically, we're really focused on bringing as many of these epic AI use cases to fruition. I'm just curious, you obviously know a lot about each one of them and are integrally involved in the research and development. Like, to an organization that hasn't started, do you have any specific, this is the one I would start with, I think this really helps clinician well-being the most? What would your advice be to someone who hasn't really taken the plunge but wants to pick one to start with?
My advice is determine what your use case is. People get into trouble when they see a shiny object and think it's a cool solution, a cool technology solution, but they don't actually have the problem at their organization, or they haven't figured out how adding technology is going to improve that problem. So first, and this is the very first thing we do when we're developing, is listen to, literally we'll have a list of a bunch of different things that we're doing in development, including a bunch of different things in AI. And we will send it to our healthcare organizations and say, will you please rank these as to what's most important to you so that we know how to develop our roadmap? And I think when I go to different talks and hear what organizations are doing, I'm always surprised that sometimes they'll choose something that's very high risk and maybe low reward. And I shouldn't say that happens often. It happens rarely. But I think you have to decide if your organization, just like any other risk management, is on the bleeding edge of things, or if you want to see how some outcomes happen first and then put something live. So to answer your question, I think most organizations are wanting to figure out how to have doctors have reduced administrative burden. And so we've seen the most adopted so far technology has really been the AI charting. And that's again in the efficiency area, but there's other places too. There's been AI in radiology and medical devices for years. And so there may be hospitals that are already, again, using AI, but are just thinking about these new use cases slightly differently. So first would be figure out your use case. Second would be, do you already have a solution? So you mentioned automation before. Can you automate it? Is what you have already something? Should you use a macro? Should you, put it in workflow a different way? Do you have to pay for AI? And so if you can come up with a solution that you already have, that's less change management and it's less cost. And then finally, if you get to the point where you have a use case and you have decided upon AI, then I see a lot of people just asking the community. So there's a ton of sharing going on as to, we tried this, it worked, it didn't work. We did ambient voice, we implemented it in family medicine and it worked great. In orthopedics, it worked great, but we tried it in integrative medicine and it didn't work as well because they have a specific note structure. Things like that, where you can learn from the community and then go forth, have been really helpful.
Yeah, and I think what you just laid out in the midst of what you just described is kind of a plug for all those local informaticists that work for these health organizations too. So this would be my plug, is get those folks involved when, operations is trying to go after a problem, because I witnessed this even at KP, and I'm sure Dale does too, at Common Spirit. A lot of times, people go after kind of like, oh, I found this solution, let's put this in, rather than really trying to think about it in the big picture. So you're getting that biggest bang for your buck, and you're implementing something that's, has a higher chance of success. Yeah.
Absolutely. Yeah, informaticists are great at that. We don't just see, back to that paper chart example, you don't see, I need to recreate this electronically. You see, how can I fix this underlying system to be more efficient and more helpful to patients? And that's exactly right. Like, there might be a technology out there that seems really neat, and maybe it is, but in your organization, does it actually serve your patients? You have to figure that out.
Yeah, absolutely. So I guess let's pivot into a couple of these other topics that we've kind of continued to mention, but, I want to touch on the interoperability piece. And I think, I'll just give kind of this like very kind of simplistic definition of interoperability from a patient perspective, because I think there's a lot of folks not in healthcare that, are listening. And I think, that's just really your ability for your information to flow across the spectrum of healthcare, so you can get care at one facility and another facility and maybe an online vendor or whatever. And ideally you want all that information to flow. And, I don't think we're at that place yet where everything is seamlessly flowing, but I think we're approaching that. And there's been these kind of iterative steps and hopefully some more significant steps, that have been kind of announced more recently. But, and I mean, you mentioned too, you've been in our capital, like talking about, interoperability from a national perspective. But, so I guess, so how does Epic view interoperability in this way? And, where's Epic leading and kind of pushing this, to help both the care teams and the clinicians, but also patients as well, because I think it plays a role in kind of both of that in that whole spectrum.
Interoperability at Epic actually started with a story from Judy's husband. So her husband's a pediatrician, and one of his patients went to a different hospital in a different state and didn't have the record. And the patient ended up dying. And the doctor said, if I just had the patient record, I would have known this one piece of information that would have actually helped me do the right course of action. And she heard about that and said, gosh, we have to fix this. We need to figure out how to get this information because this is patients' lives on the line. And so she invented what's called Care Everywhere. So if you're a patient and you have my chart, you might see something that looks like a little scripted E. It's like a CE put together. That stands for Care Everywhere, meaning that your information that you got from an outside lab or an outside organization can all be brought together and reconciled in your chart. And so we, from the beginning, have really wanted to be interoperable and are 100% interoperable. And really the goal on the national stage and how we're thinking about it is how do we get organizations that are not interoperable? And this could be, and by the way, these organizations tend to be smaller clinics, mental health clinics, things that are rural, urban safety net, nursing homes, things like that, where maybe they don't have a full-blown EHR, but they have really important information on the patient. And so, in fact, when we look at the numbers, about 70% of the hospitals in the country are interoperable, but that means about 30% aren't. And so how do we get them on board? And it used to be that we were all somewhat speaking slightly different languages. We put the information in the way that it is in Epic's database or in another database. But really, in the last couple of years, especially through ONC, they've been championing this effort called TEFCA, which you guys probably know. That's the Trusted Exchange Framework for the Common Agreement. It just rolls off the tongue. And the idea there is that you have a common set of standards, and everyone that is develops to those standards. And it helps to decrease the amount of busy work, if you will, in getting some of that information online and interoperable. And so we've had our healthcare organizations voluntarily join that. As Epic, we were the first EHR to join the pledge of doing TEFCA. And really, it just helps everybody come together and then row in the same direction. And so I feel that we've gotten a lot of change, a lot of movement over the last few years, and I think it's just going to continue to increase with TEFCA.
Yeah, I mean, quick follow up with some of this. I'm hoping, this is my hope with TEFCA, is that first it'll be kind of this, all the different EHR vendors will kind of hopefully. And I think most of them have kind of pledged to be a part of it now, which is obviously a great base. But then you mentioned that like long tail of all those other ones, all the small clinics, and frankly, all these like online telehealth solutions too. As a family doc, I mean, in urgent care, you need to know if someone is getting their GLP-1, from an online vendor, because it's not going to flow across. And I mean, so I'm hopeful in that future state that hopefully all of this stuff is going to pipe in, to something through a standard. And I think a lot of the public doesn't realize just that these standards weren't made back when these EHRs started, and it would be like if there was 10 different variations of the way electricity was put into homes, and then now, and there's obviously way more than 10 examples, I think, in information health data. But, if then all of a sudden you had to go back and figure out some sort of standard and rip out all the plugs in every house, I mean, that's sort of what we're doing, but we're working towards that future.
Yeah, I've heard about it described as cell phones, and only an AT&T cell phone can call an AT&T cell phone, and only a Verizon cell phone can call a Verizon cell phone. And what chaos would that be? We would not have the community that we have and the connections that we have. So very much that.
Yeah, pretty accurate. I think not a month or week goes by where we don't have some sort of request to, do a custom integration interface to get some specific niche data that would help us take better care of patients. But if you had to do a custom integration for every cell phone you want to call, every family member that had a different piece, you wouldn't do anything else. So I think when it comes to the things that we think are important for taking care of patients, having some of that streamlined, so that's not where we're spending all of our resources, will let us do some of the innovative things that are going to have a big impact. Speaking of innovative things, one thing that obviously has been talked about over many years now is Cosmos. And clearly, if you go to UGM every year, like Adam and I do, you get a sense that, that's really even evolved over the last 5 years, where it was sort of an idea, sign up. But I think we're getting to the point where it's really having a lot of actionable value. Can you just tell the listeners, what am I even talking about? What does it mean? And, what are you most excited for, with the reality that's coming our way?
Cosmos is a community collaboration of all of the different healthcare clinics, hospitals that are on Epic that have chosen to share their patient information so that we can have a general sense of answering public health questions and so forth. So right now that we've been using it for research, but I really think the promise of Cosmos is actually how we're going to embed it in workflow for clinicians, and also how patients can use it to help have decisions in their care. So, for example, right now, Cosmos has 293 million patient records in it, and those are deduplicated. And so having that amount of information, you can then narrow a precision cohort to a patient that's like you. So instead of taking a clinical guideline, let's say, that is very general, maybe medications for hypertension, instead of learning what I learned in med school and then what I've learned in practice and then seeing what new medications come out on the market, reading studies and so forth, I actually can use observational data, real world data from other patients, like the one that I'm going to be treating, to help inform that decision. And to me, that is getting at precision medicine and in a way we've never been able to do before, because we have clinical trials and we have people that we know are responders and not responders to certain things. But how do you figure out what makes that up? Some of it's genetic, some of it's where you live and how you're brought up. And so really tuning into that, I think, is the future of using Cosmos. So we have a couple of products that use it. So one is called Best Care Choices for My Patient. And that's pretty much what I just described, where I'm sitting in front of a patient. And we were talking about this multiple years ago, even pre-pandemic, about how can we use this vast research network and resource to be able to really change the way an individual is cared for. So Best Care for My Choices for My Patient is where you sit in front of your patient and say, I'm going to narrow a precision cohort to patients that are 60 to 65 who have hypertension with their systolic above 140 to 150, let's say, and then you put in comorbidities, you put in things like race, sex, etc., and you actually, as the clinician, kind of create what you want that cohort to be. And then you turn the screen towards your patient and you say, all right, now given your comorbidities and people like you, let's figure out what goal we want. Do we want you to get to a specific number of a blood pressure goal? Are we actually more concerned about if you have high blood pressure, are you going to get a stroke or a heart attack? Like what is the outcome we're actually looking at? And then based on that, I can use those findings to try to choose, hopefully, a medication that's going to work right the first time.
It's just such a game changer to be able to really personalized care in that level, for listeners who are not physicians, to get personalized care for yourself that's really specific to you and your demographics is incredibly difficult to have that kind of data available. So, it's just really exciting what Jackie's describing.
Yeah, so best care choices for my patient is one example. There's a few others that I'm really excited about too. So lookalikes actually came out live before best care choices. Lookalikes is on the other spectrum. So instead of talking about something really common like hypertension, think about something that's very, very rare. So I, as a primary care physician, family physician, don't always know everything to do about each specific disease, and maybe don't even know exactly how to diagnose each specific rare disease. And lookalikes, what it does is it takes information about a patient that it's a difficult case, it's like a medical mystery, you just can't figure it out, or it's a patient that does have something rare that not a ton of people, even in your practice, in your neighborhood, have been able to treat. And it then goes and finds within Cosmos patients that are like that have those same features. And it could be, again, a genetic component, or it could be just a constellation of symptoms. But the idea is it then connects you as the clinician to other clinicians throughout the Cosmos community that have patients like yours. And that way you can talk. You can communicate and say, well, this is what I tried with this patient, or this is the diagnosis I first thought, but then a while later I actually found the right diagnosis and it was this. So it can really help shorten the diagnostic journey for those rare disease patients, which is a huge thing for that population, by the way. They're thirsty for wanting to get to a diagnosis more quickly so they actually can have options of treatment. And sometimes that even includes being eligible for clinical trials that they wouldn't have otherwise have been eligible for. So that's another game changer, in my opinion, for the rare disease folks.
And you mentioned, Jackie, that, Cosmos will hopefully get to a point where it is informing patients too. Did you say that before? Yeah. Can you share a little bit about that too? Because I think, like Dale's comment that he made previously, patients want this level of personalization. They don't want to just be treated like, oh, hey, you're 45, you need colon cancer screening. You're this, you need that. And I think, that's, I think that's why there's some resistance, I think, in the public around population health initiatives, because it's not nuanced to maybe their specific level of risk or theirs. So I'd love to hear anything you can share about, how Cosmos is going to be hopefully informing even kind of at the patient level on their own or whatnot.
My dream as a family doc is that my patient and I are able to share the same information and then go back and forth and decide what really is going to be uniquely best for them. And part of that is me knowing them as a family doc, but part of that is also knowing emerging information, knowing stats, being able to use real world evidence, and taking what might be confusing and really making it extraordinarily personal. I think this actually, by the way, goes to AI as well. I have always been a proponent of, I hope that my patients maybe ask AI beforehand, what are the 5 things that I should be asking my clinician in this visit? And really get informed so that we can spend the time together as well as possible. So I do think there is a world where there's this human patient empowered plus a doctor who is now well informed by real world data and who uses AI that now can just be this amazing force for trying to cure disease. And to your point about the patients, we have tossed around the idea of developing best care choices for me, where what does it look like to ask those same questions in a HIPAA compliant, data rich environment for a patient? Because we're all nerds, we all like data. That's one of the joys of medicine, is to try to really get to the right answer, and the right answer is so unique to each individual. So I see a future where all of those things come together, and it's not just what have we done 5 or 10 years ago, or even in medical education, it's not just what did your mentor tell you in medical school that maybe they did 10 to 15 years ago, but what actually should we be teaching people, and how up to date should that information be so that they can take the best care of the patient.
Very cool. And you actually I guess my lead into that was the last question we were going to ask, was kind of like what excites you about the future. So you answered that so lovely. So I guess in the last like few minutes we have here, we always like to end our shows with kind of our fun, lighthearted nerd alert round. Are you happy to participate in that with us?
You bring it on.
Okay, cool. All right. So some of this is like a little bit of knowledge share. Some are just kind of fun things. So first question I have, and for the record, we don't give people these questions ahead of time. So we sometimes prep them on the general flow of the podcast, but we don't give them these because we really do want that kind of like off the cuff. So do you have personally like a favorite productivity hack or solution that you like, that you love to use?
Personally, I have found AI has changed the way that I think about solving problems. So I do think the year of 2025 and beyond is going to be a year of agentic AI. So we have, a buddy in our pocket at all times. So I use both Microsoft Copilot and ChatGPT, and I find them to be good hacks, I guess, if you will call them that. But they're more just helpful tools. Professionally, as a physician in Epic, I love both chart search and probably more importantly, the chat, like how you can actually do secure chats back and forth with your team. Paging was a nightmare, and I'm just really grateful to not have to hold 4 pagers on my belt. It was the time where it was like you have the trauma pager, and you have the resident pager, and you have the clinic pager, and you have the hospital pager, and you oftentimes wouldn't know how to best prioritize things. And I think that we've gotten to a place where we can prioritize what we need to do as physicians. And so that's kind of my clinical hack.
What is the last book you read or podcast you listened to?
So I've listened to a couple of podcasts recently. I recently was listening to there's a stat podcast, and it had a little bit of recap around what happened at JP Morgan earlier this week. And then for a book, I go back and forth between leadership type books and also fun books. So there's a series by Daniel Silva, which is about espionage that I think is really fun. And then I most recently reread Good to Great, and I also read Brotopia.
Very cool. So Dale and I love it when we travel back to Wisconsin and get our share of some of the culinary delights there, like cheese curds and whatnot. But do you have a go-to comfort food that you enjoy after a long day?
Yes, I love popcorn. That's one of my go-tos when I need a snack. In terms of at the end of a long day, if I'm really hungry, anything pasta. I come from partial Italian background, and so I love making homemade pasta. So when I do that, and I know it's frozen in my freezer, I'll go home and cook that up. So I think those are probably the main ones. And then when I was a little kid, we had a deli here called Ella's Deli. Ironically, it actually shut down a while back, and Epic purchased the carousel that was outside of the deli, and it's now in our learning campus. But I used to go there as a kid and get Blue Moon ice cream, which sounds horrible. And now that I'm a physician, I'm like, oh my God, can't believe I did that. But I would also get matzo ball soup, and that was absolutely the comfort food of my childhood.
Yeah, you're speaking Dale's language for both of those.
Yeah, well, we do a lot of popcorn in our house, a lot of homemade pasta, and certainly some matzo ball soup. So yeah, and it's good to learn a story about the carousel.
Yeah.
Other than that interesting thing that we learned about you, what's one thing that people might be surprised to learn about you? Or because you know so much about Epic, which is a secret to so many of us, something that surprised you to learn about Epic that you want to share? You could take it either way or both.
I'll start with Epic. I think the thing I was most surprised to know when I started here was that Judy has signed to be part of the 99% club that gives everything away to charity. And also that the buildings that are on campus pay for themselves in a matter of a couple of years due to staff productivity. And I think that, to me, both of those things, especially the 99% one, help me understand her vision, what she's trying to do for healthcare, and why this is so important to bring all of this information together to try to improve health. It's not it's not a typical, she calls herself the accidental CEO because people kept being like, hey, you have this project, start a company. And she finally did. And I think that's so different. The business case, the story is so different than most startups nowadays. We're private. We don't take VC or PE funding. And it's just such an interesting contrast, and it really helps to understand the culture that's here at Epic. You don't really understand the culture until you step foot on campus and kind of see how things are done, in my opinion. In terms of things that might surprise you about me, I recently was in South Africa, and in attempting to try to help a penguin back onto the ocean, it had a pet friend penguin that thought I was trying to hurt it, and it bit me on my leg, which I immediately then went back and was like, is there an ICD-10 code for bit by penguin? And I swear I will use that in my 3 truths and a lie in the future. But I had a little bruise for a while. It was kind of fascinating.
That is definitely something that I wouldn't have expected you to say.
All right. Last question. Not related to AI. Is there a piece of technology that you feel like you couldn't live without? And it can't be your phone.
That's hard. In the process of trying to take myself more analog when I disconnect, I find that I'm always brought back to things that people create that are not in written form. So for example, this podcast, if I do really think that some of the most amazing ideas, the ways that we're changing the world right now are all interconnected with technology. And there's not a day that goes by where I don't want to learn something new. I think all of us as physicians always are in this continual learning. And I think if you were to take away the different exchanges, the podcasts, the conferences that are online now, like the way that we changed as a world during the pandemic to be so technologically driven, I think that we need to embrace that and be able to learn by using technology. And I would be so sad if that would slow down my progress, our progress, learning progress.
Yeah, love that.
Well, I think that we are wrapped up, and I think we've said it all. I really appreciate, you sharing that whole story. I mean, I think a lot of listeners probably, whether they are in the shoes similar to us, or maybe they're dreaming of those, just to hear that, that you're out there solving those problems. And, I'm happy to hear that another fellow family physician is out on the front lines, kind of leading us towards that future you described. I mean, that's exciting. Any last words, Adam?
No, I mean, we just like to have our guests, if there's anything that they wanted to wrap with or something that they feel like they didn't get to say based on the questions we asked. But it was a pleasure having you on, Jackie. Really appreciate it, and wish you and Epic the best of success going forward.
Yeah, thank you so much.
Thank you for listening to Efficiency Unlocked, Nerd Tested, MD Approved, a Nerd MD's podcast by Drs. Adam Carew and Dale Gold.